Before 2020, nursing education relied on physical presence, continuous on-campus learning, and direct interaction. In March 2020, the WHO declared a pandemic. The resulting global shift to strict social distancing protocols delivered an immediate systemic shock. Due to this rapid spread, nursing schools worldwide were forced to shutter their physical campuses and abruptly halt all in-person attendance. Simultaneously, the infection risks and the immense workload on hospital staff led to the removal of nursing students from clinical practicums in the most severely affected regions. Clinical researchers faced the same locked doors, severing their ability to meet face-to-face with patients and their families. At the exact historical moment nursing care was most critically needed, the traditional mechanisms to train students and conduct clinical research were largely suspended. The profession could not pause. It required an immediate, structural evaluation of its core methodologies. This transition is tracked on two intersecting axes. The vertical axis represents the macro-systemic shift toward digital infrastructure. The horizontal axis tracks the microclinical reality. This is the ongoing need to rigorously test patient interventions and evaluate the workforce delivering care. The evolution of the field occurs at the intersection of digital shifts and continued clinical rigor. The loss of physical classrooms drove the rapid adoption of what is often referred to as untacked environments, learning spaces engineered to be non-face-to-face and contactless. Virtual classrooms were deployed to simulate real-time interactions between students and educators, attempting to replace lost field training. This transition exposed immediate friction points. Deep educational disparities emerged, dictated largely by the IT infrastructure of individual institutions. Students with limited digital literacy or poor access to electronic resources found themselves at a disadvantage in exclusively online environments. Despite these localized disparities, remote learning offered the ability to provide learning opportunities across diverse geographic areas without requiring physical travel. Based on these geographic advantages, current analysis suggests that even after the pandemic, education is more likely to maintain blended systems rather than returning to a predominantly face-to-face model. The macro-educational shift decentralized learning, forcing academic institutions to address digital equity alongside pedagogical care. This decentralization also hit the research sector. With researchers locked out of physical wards, face-to-face qualitative interviews and surveys were replaced by telephone and online data collection. To compensate for the lack of direct observation, researchers adopted technologies to extract data remotely, integrating artificial intelligence, wearable medical devices, and virtual reality. These digital nursing technologies integrate into hospital information systems and electronic health records, allowing researchers to monitor patient care processes from a distance. The structure of the research itself shifted. The field moved toward more interconnected, collaborative research teams rather than individuals working in isolation. The barrier to physical entry moved the research sector toward a model of digital data extraction and remote collaboration. While the macro shift dictates how research is conducted, clinical researchers must still prove what specific interventions actually work on the front lines. This forest plot visualizes a meta-analysis evaluating nurse navigators, specialized personnel guiding patients from cancer screening through their first treatment. The data reveals a favorable outcome. Nurse navigators improved care timeliness, reducing wait times with a mean difference of 20.42. These navigators yielded the highest impact when embedded as key members of multidisciplinary programs. This clinical validation extends to alternative therapies as well. A systematic review measured the impact of lavender aromatherapy compared to placebos. This split bar chart displays findings using Hedges G, calculating standardized mean difference to show effect strength. The analysis reveals substantial effect sizes. Lavender therapy yielded a Hedges G of -0.72 for anxiety and -0.43 for depression. Establishing clear, quantitative differences compared to placebos provides the necessary evidence to justify the integration of these therapies into active patient care. But testing doesn't always yield positive correlations. Take the randomized trial of a thermoelectric element band, applying thermoillusion therapy to reduce pain during venipuncture. The device generated high subjective patient satisfaction, yet compared to the control group, it failed to show any statistically significant difference in actual pain or anxiety reduction. This discrepancy shows that measuring qualitative states, like a patient's feeling of support, requires highly validated, specific academic scales. This five-pillar structure illustrates the perceived nursing support scale for mothers of preterm infants, developed to quantify emotional and practical support. The scale categorizes support into 5 factors: baby care, mental care, maternal role, introducing resources, and information delivery. This tool demonstrated high reliability, achieving a Cronbach's alpha of 0.95. Cronbach's alpha is a measure of internal consistency, confirming that the test reliably measures the factors it claims to evaluate. Without rigorous randomized controlled trials and validated psychometric scales, the profession risks adopting treatments based on subjective satisfaction rather than statistical evidence. This same analytical rigor is required when turning the lens inward to evaluate the internal equity of the nursing workforce. This qualitative node map visualizes a study of male nurses in South Korea, uncovering complex social dynamics. It identified multidimensional gender discrimination from broad sociocultural factors and revealed the subtle, ambiguous nature of sexual harassment experienced in this female-led profession. Correcting these issues involves institutional action, such as moving away from gender-classified roles and creating specialized protocols for reporting inequality that acknowledge male vulnerabilities. A resilient medical workforce requires continuous, qualitative auditing of internal equity and bias, alongside technological upgrades. There has been a massive influx of digital technologies and virtual care systems at the macro level since the onset of the pandemic, but an evidence gap remains. While many of these digital tools report positive effects, the level of statistical evidence supporting them is currently categorized as relatively weak or based on small sample sizes. The rigorous standards applied to clinical interventions, like nurse navigators and clinical trials, have not yet been fully applied to the rapidly deployed digital infrastructure. The macro-systemic shift currently operates on an assumption of efficacy that requires further micro-clinical rigor and large-scale validation. Now the macro-digital infrastructure and the micro-evidence-based realities are finally being brought into a state of direct alignment. Blended learning systems, digital data extraction, and remote patient care have become standard fixtures of nursing practice and research. The current goal for nursing educators and researchers is to generate high-quality data that holds digital procedures to the same standards as physical care. Operating on these two fronts, technological innovation and clinical proof, provides a path for the profession to lead a successful transition into the remote era.